Thank you so much, Mamangge, for that very kind introduction. And thank you also to the scientific committee for inviting me to speak on the topic preparing to conceive. So this lecture is divided into two parts. The first part is on optimizing natural fertility, and this will be based fundamentally on the basic concepts of preconception care. And also we try to address our patients' frequently asked questions regarding coital timing, frequency, and practices. For the second part, which is the basic infertility workups, I will discuss some very basic infertility evaluation that a general gynecologist can request for our patients who failed or are having difficulties to naturally conceive on their own. So first off, we educate our patients regarding their chances of conception. So couples who are concerned about their fertility should be informed that over 80% of couples in the general population will conceive within 1 year if, number one, the female partner is less than 40 years old, and number two, the couple does not use contraception and has regular sexual intercourse. Now, for those who do not conceive during the first year, about half will do so during the second year, with a cumulative pregnancy rate of over 90%. So now let's talk about ways by which we can optimize or boost our patients' natural fertility. So for this first part, I shall discuss the importance of preconception care and address our patients' concerns regarding any medical comorbidities that they may have, vaccination prior to getting pregnant, issues on weight optimization, diet, exercise, and vitamins. So preconception care is the process of identifying social, behavioral, environmental, and biomedical risks to a patient's fertility and pregnancy outcome with the goal of reducing this risk through education, counseling, and appropriate intervention. The main goal of preconception care is to provide health promotion, screening, and interventions for women of reproductive age to reduce risk factors that might affect future pregnancies. Now, the goals of preconception care is to reduce the risk of adverse health effects for the woman, the fetus, and neonate by working with the woman to optimize her health and also to address modifiable risk factors and provide education about healthy pregnancy. So ideally, a patient who is fit for pregnancy is a woman who has adapted a healthy lifestyle or behavior such as eating a healthy diet, taking folic acid supplements, and has regular physical activity. Now, a woman who is fit for pregnancy also should have addressed and discontinued any unhealthy lifestyle or habits that put her at risk by diminishing her chances of pregnancy or increasing chances of adverse pregnancy outcomes. And this unhealthy lifestyle includes smoking, alcohol, and substance abuse. Now, many chronic medical conditions should be optimally managed before pregnancy. And these medical conditions include diabetes, hypertension, psychiatric illnesses, and thyroid diseases because this has implications for pregnancy outcomes. Now, hypertension should be controlled prior to conception, and women on antihypertensive drugs who have normal BP or mild hypertension with no end organ damage may be transitioned off of medication with close monitoring of BP response and reinstitution if BP increases to potentially morbid levels. Certain agents such as ACE inhibitors and ARBs should be avoided during the periconception period, and patients who are in any of these agents should be advised to switch to agents whose safety in pregnancy is established. Also, thyroid disease requires close monitoring of thyroid function as both hyper and hypothyroidism can affect fertility and pregnancy outcomes. Women who receive radioiodine should defer pregnancy for at least 6 months. Women who have history of seizures and women taking anti-seizure drugs should also receive thorough information about the risk of pregnancy for the mother and the fetus and adjustment in their drug regimen and folic acid supplementation to reduce the risk of neural tube defects. Now, in particular, valproate should be discontinued if seizures can be adequately controlled with an alternative drug. And since valproate appears to be a more potent teratogen than other anti-seizure drugs. All prescription and non-prescription medications should be reviewed during pre-pregnancy counseling, and this review should also include nutritional supplements and herbal products that patients may not consider to be medication use, but could affect reproduction and pregnancy. So medications with potential teratogenicity should be reviewed, and the specific risk of each individual medication should be discussed in detail. All patients should be routinely asked about their use of alcohol, nicotine products, and drugs, including prescription opioids and other medications used for non-medical reasons. Now, it appears that smoking accelerates follicular depletion and the loss of reproductive function. There's actually a meta-analysis that compares smoking women with non-smoking women and concluded that the smokers were actually twice as likely to be subfertile. Smoking was also found to be associated with a higher risk of spontaneous abortion and ectopic pregnancy. Women of reproductive age should also have their immunization status assessed annually for tetanus toxoid, reduced diphtheria toxoid, and acellular pertussis, hepatitis B, MMR, and varicella. This is a table that shows to us the summary of recommended immunization for Filipino women. So as you can see here, tetanus, diphtheria, pertussis, influenza, and hepatitis B vaccines can all be given for pregnant women. And the HPV vaccination currently is not recommended during pregnancy, but should not be avoided or delayed because a woman may want to become pregnant or may be actively trying to become pregnant. Now, if the HPV vaccine series is started and the patient does become pregnant, completion of the vaccine should be delayed until that pregnancy is completed. Now, vaccines for MMR and varicella should be given at least 28 days before pregnancy or in the postpartum period if not yet previously given. Because 2 doses of the varicella vaccine are recommended, and the CDC recommends that women do not become pregnant for 1 month after being vaccinated. A woman who desires pregnancy should begin vaccination 2 months prior to attempting pregnancy. Now your patients ask you, "Doctor, should I lose or gain weight?" Now, patients should be encouraged to try to attain a BMI within the normal range before attempting pregnancy because high or low BMI is associated with infertility and maternal and fetal pregnancy complications. The reproductive risk of obesity include but are not limited to infertility, miscarriage, birth defects, preterm delivery, gestational diabetes, gestational hypertension, cesarean delivery, and thromboembolic events. Obesity also increases the risk of non-reproductive diseases, including stroke, heart disease, certain types of cancer, arthritis, high cholesterol, hypertension, and diabetes. Now, pregnant women with low BMI, on the other hand, are at high risk also of having SGA fetuses and low birth weight infants. Now, if you have an obese patient, what should you advise her so that she attains her weight goals? No, so of course you advise her proper diet or restriction in the caloric intake, and of course regular physical exercise. Regular physical exercise improves cardiovascular health and reduces obesity and its associated medical comorbidities. Patients should exercise moderately, at least 30 minutes a day, 5 days a week, for a minimum of 150 minutes of moderate intensity exercise per week. These levels of moderate intensity exercise are recommended pre-pregnancy, even during pregnancy, and in postpartum women. Dietary modifications in concert with exercise produce greater weight loss than exercise alone. So just to give you an idea what counts as a moderate physical activity, so this is a very nice diagram showing to us some examples of moderate intensity physical activity, such as brisk walking, gardening, tai chi, dancing, cycling, active recreation, swimming, and even household chores such as vacuum cleaning or mowing the lawn. Now, patients should also be screened regarding their diet and vitamin supplements to confirm they are meeting recommended daily allowances for calcium, iron, vitamin A, vitamin B12, vitamin B, vitamin D, and other nutrients. Fruits, vegetables, and daily multivitamins are good sources of antioxidants and vitamins that may assist in reproductive health for for both the males and the females. And patients who are at risk of eating disorders or those maintaining a very low caloric diet should be screened and counseled. And patients also with malabsorptive gastrointestinal disease, bariatric surgery, or those on a vegan diet may require vitamin and mineral supplementation. Reproductive age women should be encouraged to take folic acid supplementation with 400 micrograms per day to reduce the risk of neural tube defects. Now, for women at increased risk of NTDs, including women with a prior pregnancy with an NTD or women with seizure disorders, they should be counseled to take at least 4 milligrams of folic acid daily. Women trying to conceive should be advised to limit caffeine intake to less than 200 milligrams per day and alcoholic drinks to 1 or 2 units or standard drink of alcohol once or twice per week. Excessive caffeine intake in women is associated with increased infertility and increase in time to pregnancy, and among pregnant women, it is also associated with miscarriage and preterm birth. Excessive alcohol intake, on the other hand, is also associated with increase in infertility, and in males, excessive intake of alcohol causes lower semen volume and is harmful to sperm morphology. Now, just to give you an idea what 200 milligrams of caffeine looks like, or approximately looks like. So one small cup of brewed coffee has about 150 milligrams of caffeine. Instant coffee has about 110 milligrams of caffeine. Black tea, green tea, and white tea all has or all contains less than 50 milligrams of caffeine, and even decaf has a little bit of caffeine, about 8 milligrams. For the alcoholic drinks, one standard drink is about 12 ounces of regular or light beer, and also one standard drink is also equivalent to about 4 to 5 ounces of white or red wine. So next, we address our patients' common or frequently asked bedroom concerns, that is, coital timing, coital frequency, or coital practices. So now let's talk about coital timing first. So for counseling purposes, the fertile window is best defined as the 6-day interval ending on the day of ovulation. At least in theory, the viability of both oocytes and sperm should be maximal during this time. Now, for clinical purposes, the interval of maximum fertility can be estimated by analysis of intermenstrual intervals, ovulation predictor kits, or cervical mucus scores. Intercourse is most likely to result in pregnancy when it occurs within the 3-day interval ending on the day of ovulation. Ovulation detection devices can also help our patients to determine their fertile time, and we can advise them to use LH detection kits, or what we call the ovulation kits, that's readily available in the local pharmacies. And these LH detection kits detect the mid-cycle urinary LH surge, and once the kit tests positive, ovulation may occur anytime within the 2 days thereafter. And the interval of greatest fertility will be on the day of LH surge and the next day. So also advise your patient that this test is best done using midday urine specimen. How about coital practices? So there's no evidence that coital position affects fecundability. No, sperm can be found in the cervical canal seconds after ejaculation, regardless of any coital position that they assume. And although female orgasm may promote sperm transport, there is no known relationship between orgasm and fertility. And also, there is also no convincing evidence to indicate any relationship between specific coital practices and infant gender. Now, so what if the couple is experiencing some difficulty conceiving despite practicing all these preconception guidelines for optimizing natural fertility? Then we proceed to infertility evaluation. Now, this table summarizes the basic infertility evaluation procedures that the general gynecologist can do prior to referring the patient to an infertility specialist. Of course, it goes without saying that we have to do a thorough history and physical exam, and we can also request for laboratories to detect ovulatory dysfunction, tubal factor, uterine factor, male factor, and even diminished ovarian reserve if necessary. So for women older than 35 years old, they should receive an expedited evaluation and undergo treatment after 6 months of failed attempts to become pregnant or earlier if clinically indicated. Now, for women older than 40 years old, more immediate evaluation and treatment are warranted, or better yet, please refer them immediately to a reproductive medicine specialist. Now, if a woman has a condition known to cause infertility, the obstetrician gynecologist should offer immediate evaluation. And what are these conditions? These include the following: oligomenorrhea or amenorrhea, known or suspected uterine, tubal, or peritoneal disease, endometriosis, or known or suspected male infertility. Now, as I've said, it's very important to do a thorough medical history and physical exam, and a comprehensive medical history, including items relevant to the potential etiologies of infertility, should be obtained from the patient and her partner. A targeted physical exam of the female partner should be performed with a focus on vital signs and include the thyroid, the breast, and of course, pelvic exam. And here are the key historical factors that you should elicit from the patient. So this is a very long list of historical data that you should elicit from your patient. So please take note of this. And here are the key physical factors that you should also obtain from your physical exam. Now, for the diagnostics, for the female partner, tests will focus on ovarian reserve, ovulatory function, and structural abnormalities. Imaging of the reproductive organs provide valuable information on conditions that affect fertility, and imaging modalities can detect tubal patency and pelvic pathology and assess ovarian reserve. Now, ovarian reserve tests should not be routinely done for all infertility patients, and they should be done only for female patients who are or have the following conditions. For female patients who are 35 years old and above, for patients with a history of pelvic or ovarian surgery, history of chemotherapy, family history of early menopause or premature ovarian failure, history of poor response to infertility treatment, or those patients who are planning to undergo ART or IVF. The presence of decreased ovarian reserve predicts future response to ovarian stimulation. And although there are no definitive criteria for diminished ovarian reserve, the following values may be considered consistent with diminished ovarian reserve. So we have an anti-Mullerian hormone or AMH value that's less than 1 nanograms per ml, AFC or antral follicle count less than 5 to 7, FSH greater than 10 IU per liters, and history of poor response to in vitro fertilization stimulation with fewer than 4 oocytes at the time of egg retrieval. Now, here are some of the tests that should not be done or should not be routinely ordered. And this includes laparoscopy for unexplained infertility, advanced sperm function testing, post-coital testing, thrombophilia testing, immunologic testing, karyotyping, endometrial biopsy, and prolactin. So we order this test only when necessary. So we can also evaluate for male factor infertility. And of course, we start off with obtaining the male partner's medical history and of course, order for semen analysis. Now, we can refer male infertility patients to a healthcare specialist with expertise in male reproductive medicine. Now, other tests to include are the following: monitoring for ovulation, checking uterine and tubal factors, and of course, checking for male factor infertility. And all of this will be discussed by the succeeding speakers in this session. Okay, so in summary, we have discussed ways on how to optimize or boost natural fertility of our patients. And under this, we have covered preconception health, advices on screening for medical comorbidities, and the importance of addressing this prior to pregnancy, proper diet, weight optimization, vitamin supplementation, caffeine and alcohol intake, and even some tips on coital timing, frequency, and practices. We also discussed a brief overview of the basic fertility evaluation that a general gynecologist can do, and a more detailed discussion of this will be given by the succeeding lecturers. That's it for my lecture, and thank you for your kind attention.